Thank you for joining me today. In this video, we are going to go over benzodiazepine. Benzodiazepine is a class of medication. It has different indications and side effects. That is what are we going to go over this medication. Stay tuned. So benzodiazepine is a class central nervous system depression, GABA A receptor positive, allosteric modifier. It is, and the common agent is, it's controlled substance. It is anti-anxiety medication. And some of the common classes of a benzodiazepine is Ativan, alprazolam, lorazepam. So they end with lam or bam. Diazepam, clonazepam, midazolam, temazepam. So their end is lam or bam. So benzodiazepine is indicated for anxiety, panic, acute agitation, sedation. So midazolam is a good for acute agitation and insomnia. Benzodiazepine is also used in insomnia for only short-term usage. It used for sedation, for seizure disorder, epilepsy, especially lorazepam and diazepam is used for seizure and epilepsy, steady epilepsy. They are first line of treatment for alcohol withdrawal. They are also used in muscle spasm and spasticity. So benzodiazepine is approved for anxiety, panic, agitation, sedation, insomnia, seizure disorder, epilepsy, alcohol withdrawal, muscle spasm or muscle rigidity. However, they have serious side effects that you have to monitor and watch out. Benzodiazepine common side effects include sedation, drowsiness, dizziness, impaired coordination, cognitive slowing, confusion, especially older patients. However, serious side effects include respiratory depression. That is also dose related. Risky with opioid and alcohol. What I mean is, if you use benzodiazepine with opioid or alcohol, it can depress your respiratory and that can lead to coma or death. It also, some of the serious side effects include dependency. People get dependent with benzodiazepine. tolerance, withdrawal can be life-threatening. So dependency, withdrawal, and tolerance is a life-threatening serious side effects. It increases the risk of falls, fracture, and delirium for older adults. That is one of the serious side effects of benzodiazepine is increase the falls, fracture of the bones and hips, and delirium, because older adult, they have lower tolerance with the medication because they don't clear the medication from their body quickly. Also, they are already risky for falls, already for risky for fracture, already for risky for dementia or confusion. This will increase that. This medication will increase all these issues for elderly. So, what do you monitor? You monitor level of a sedation. You monitor a respiratory status, especially during the initial dosage or dosage change. You will assess the cognitive function and fall risk, particularly older adults. You will assess sign of misusage, dependency, tolerance, diversion. You will check PDMB, early refills. You will also assess the concomitant for central nervous system depressant usage like opioid. You want to assess if they are using opioid, if the patient is using opioid, alcohol, GABA A. All this will depress the nervous system more and can lead to coma and death. You will also want to assess the withdrawal symptoms when tapering. You want to assess, how do you going to assess the withdrawal? You want to assess the signs of withdrawal. You want to assess tremors, shaky, anxiety, seizure. So benzodiazepine withdrawal is mimic like alcohol withdrawal. So you will want to watch same symptoms as the alcohol withdrawal. You want to educate the patient for this medication is used only short term only, unless specifically directed. Most indicated is 1 week. Do not stop this medication quickly because it can lead to withdrawal symptoms and seizure. It's like alcohol. Everything that you see alcohol withdrawal, you can see benzodiazepine withdrawal. That's why you want to treat the alcohol withdrawal with benzo. You want to taper this. You want to ease the alcohol withdrawal with the benzo, so you can control the situation and lower the withdrawal of the alcohol. But if you withdrawal with the benzo quickly, you can create same as the alcohol withdrawal. Avoid alcohol, avoid opioid usage, avoid sedative medication unless appropriate by the provider. Do not drive or operate machinery until you know how this medication affects you, because it can alter your awareness, cognition, because it's sedative medication. store circulates that are controlled substances with abuse potential. Most benzodiazepine that I've seen is the in hospital. I never seen out hospital being used this medication. So it just use the 3 days or 4 days that the patient is in the hospital, and then you will discontinue before they discharge because it's short-term use. Clinical oral include is a short-term active agency. Alprazolam is a higher abuse and withdrawal. Alprazolam has a higher abuse and withdrawal risks, and it used short term. Long term, it's also long. It's a short acting. Alprazolam is a short acting that has a higher abuse and withdrawal risks. Diazepam and clonazepam has a long-term act and prefer for withdrawal tapering. So you use the alcohol withdrawal with the long-term acting benzodiazepine like diazepam and clonazepam or diazepam. Those are the one I seen being used with the alcohol withdrawal patients. When you want to treat alcohol withdrawal and you wanted detox, I have seen that detox patient when they are admitted to the hospital being used this medication like diazepam and clonazepam with the withdrawal symptoms, alcohol withdrawal symptoms. Lab drugs like lorazepam, acetaminophen, temazepam are safer in a liver disease or elderly, not acute metabolisms. There is a black box warning concerning the use of an opioid. It increases the risk of a coma and death if you use with the opioid and alcohol with benzo. There is a black box warning about that. Flumaxylin is the anti-dosage, but generally avoid in a chronic users due to a seizure risk. Flumaxylin is the anti-dosage that treats the withdrawal symptoms of a benzo, or you will use that benzo overdose. But you have to avoid because it can create seizure risks. It's not the first line for chronic anxiety. Benzo is not the first line of anxiety. It prefers to use SSRIs and SNRIs for long-term usage for anxiety. It's just a short-term usage. And SSRIs and SNRIs are preferable for anxiety for long-term use. I have case study based on benzodiazepine. So our case study is it was a Friday night in the emergency department when I met Mr. B, a 62 years old man, brought in by his wife for anxiety, shortness of breath, chest tightening. He has anxiety and he's feeling short of breath and chest tightening. By the time I saw him, minor monitors were on the lab were bending. So the lab was bending. And his breath was fast but shallow. He kept asking the same question over and over again. Am I dying? Cardiac work up so fast was reassuring. Oxygen saturation was normal, no fever, no focal neurological findings. What he was experiencing was not structural or infection. So why he is having a short of breath? Why he is saying, am I going to die? Why he is anxious like that? That's what I was asking in my head. It was panic. He was panicking. It was raw and overwhelmed and confusing. He had a history of a generalized anxiety disorder. He had been coping reasonably well until early that week when he lost his job. So this man had a general anxiety before and he lost his job, and that increases anxiety and that caused him panic and overwhelm. Tonight, the anxiety had tapped into something he could not longer ride out on his own. So we try first to slow things down, reassure him, coaching his breath, explain to him what we know and what we were ruling out. It helped him, but not enough. His hand is still shaky. His pulse were not coming down. The fear stay loud, so he was fearful. That is when Benzo entered the room. That is when I thought of Benzo. They are familiar, powerful, effective, heavy with consideration. A small dose was given. Within a minute, the changes was visible. His shoulders dropped. His breath slow because he was panicking. Okay. Panic loosen. It is grip. Not erased, but something enough for him to hear us again. He made eye contact. He stopped apologizing for causing. He made eye contact and stopped apologizing for causing trouble. But even as the room calms down, I felt the familiar tension that comes every time Benzo work. Exactly the way they are supposed to. Because they don't just treat the anxiety, they shorten the circuits, and that matter. I review his chart more carefully. He did being prescribed benzodiazepine years earlier as needed, and that quietly thrive into daily usage. Not misuse dependency, the thing that develop slowly, invisible, and so he was not misusing, but he became dependent. Tonight, those help, but it did not solve the bigger problem. We talked openly once he was calm enough about how benzodiazepines are best used as rescue tools, not structural support. About the tolerance, I talked to him about the tolerance, about rebound anxiety, about the danger of letting a refill turn into routine. You don't want to refill this medication again and again because that shows the dependency. Before discharge, we made it a plan not just for tonight, but for what comes next. That case stay with me. How? Because it captured the truth about benzodiazepine better than any textbook. They can rescue the movement. They can slow down the panic symptoms and quietly complicate the future. You see? It can rescue the moment and complicate the future. You just want to treat the quick panic episode, but they can affect the future. How are you going to discontinue them or stop them? Are we treating acute distress or avoiding the discomfort? Is this a bridge or are we building a dependency without naming it? Those are the questions you have to ask for. Do we have a plan beyond the next dose? Are we going to treat acute stress or we are avoiding discomfort? Benzodiazepine can be compassionate, appropriate, even life-saving, but only when used deliberately, transparently, and temporarily. You only want to use deliberately and temporarily to just lower that panic symptoms that the patient feels that they are dying, they can't breathe, their respiratory is running around, they are anxious. So benzodiazepine is indicated acute, severe anxiety and panic. Catatonia, alcohol withdrawal, seizure activity, short-term relief when non-pharmacology measures are not sufficient. That's when this is the things you use for. So the strategy, medication strategy you want to use are use the lowest dose effectiveness. Lowest effectiveness dose. Use the lowest effectiveness dose. Prefer time limited, goal directed use. Avoid routine schedule dosing unless clearly indicated. Avoid co-admission of opioid and alcohol. So don't take alcohol or opioid with this medication. Reassess the necessity of the frequently. Why do you need the medication? Why this patient need that medication? There is other medications that are not risky like this one, that don't create the dependency or withdrawal. So you have to plan for that. Our next plan is address the underlying drivers of anxiety and agitation. What is causing this panic? What is causing this agitation? That's when you want to address, not just giving benzodiazepine. You want to transition to non-benzodiazepine long-term strategy, such as using a SSRIs medication and therapy to treat the panic and anxiety. You want to have a clear tapering or discontinue plan if used beyond a single dosage. You want to have that balance. Before you even start, you have to have those balances. So for the patient education, I explain clear and directly. Benzodiazepine reduces anxiety quickly, but their effects fade. Repeat use can lead to tolerance and dependency. Repeat usage can lead to tolerance and dependency. Anxiety can rebound strong when the medication is wear off. So even though you want to treat this use this medication to control the anxiety, when you stop, the anxiety can come back strongly if you don't wean it off. Stopping suddenly or after a regular use can be dangerous. Because it can lead to seizure. So we review together using the benzodiazepine only as a prescribed. Avoid alcohol and other sedation medications. Not driving or engaging in high task activity when you're taking this medication. Importance of a follow-up for long-term anxiety management. You want to set a follow-up appointment and you want to educate the patient to the importance of a follow-up for long-term management of anxiety, therapy, other medication, SSRI and their side effects. You want to monitor the side effects of sedation, cognitive slowing, memory impairment, dizziness, respiratory suppression, especially if used with opioid, alcohol, and if the patient has already lung diseases. It also affected the psyche. It affected the nervous system, respiratory. It also increases the sedation and increases the agitation. It also leads to emotional blunting, flat effect, worsening anxiety with the long-term usage. It can worsen the anxiety if you use long-term. It leads to dependency and withdrawal symptoms, tolerance with continued usage. Withdrawal symptoms of stopping abruptly include anxiety, insomnia, and seizure. It can lead to falls, especially the older adult, impair driving and coordination. The outcome that you want to gain from giving this medication is a acute panic resolved safely. Because this patient was scared and worried about that they are dying, you just want to control that panic. You wanted them to have normal respiratory. You wanted them to have normal. You want to also check no respiratory compromise, no overdose, over sedation, no respiratory compromise or overdose sedation, no acute panic, no cardiac, and you want a cardiac and medication walk up reassurance. You want to assist those. The outcome will be discharge with clear plan and follow up. You want to educate and provide education on benzodiazepine risks and alternative medications. You wanted them to have long-term anxiety medication. You want to prioritize that long-term management of the anxiety. It's not just a quick fix, but long-term management. My question to you is, when benzodiazepine work quickly and effectively, how do you resist the temptation to let them become the answer? You don't want them to be the answer. They will never be the answer. How do you reframe their use to the patient as a temporary rescue rather than a long-term solution? They are not a long-term solution. That's how you educate the patient. So my question to you is, how do you frame their usage to the patient as a temporary rescue rather than a long-term solution? How you do that? Think about those questions. Thank you for joining me today. I will love to see you in my next video. Thank you.